All right, let's jump right in. Today we're looking at the dynamics of root caries in our older patients, and we're basing this explainer on a really fantastic clinical trial by León and colleagues. This gets to the heart of one of the biggest challenges we face in gerontology. So why does this topic matter so much? What's the big deal? Well, get this. Root caries lesions are the single #1 reason for tooth loss in older adults. That right there, that's a huge clinical problem that we need to get a handle on.
And it's a challenge that's only getting bigger. People are living longer and, thankfully, keeping their teeth longer too. But the downside is that means more exposed root surfaces and a higher risk for this kind of decay. This is way more than just a dental issue. It affects their ability to eat, their nutrition, and their overall quality of life.
So, that brings us to the million-dollar question that this study really tries to tackle. It's not enough to just stop a lesion once. What we really need, what our patients need, is a non-invasive way to keep these lesions under control for the long haul. So how do we actually do that? Well, to find out, the researchers set up a classic head-to-head clinical trial. They took 2 different types of fluoride toothpaste and put them to the test over a 2-year period. This is where we start to see some really clear evidence emerge.
Okay, so here was the setup. In one corner, you've got the control group, using your standard, off-the-shelf toothpaste with 1450 parts per million of fluoride, and in the other corner, the intervention group, using the heavy hitter, a prescription-strength high-fluoride toothpaste with 5,000 parts per million. They followed both groups for 2 full years to see what would happen.
And the results, well, they were pretty staggering. Let's just say this wasn't a close fight. Let's break down how these two really performed in what I'm calling the stability showdown.
Okay, now just look at this chart for a second. The difference here is night and day. After 2 years, in the standard fluoride group, almost half, we're talking 47.9%, of the lesions were still active. But look at the high fluoride group. That number just plummets to 4.3%. That is a massive improvement.
But here's the thing, and as clinicians, you know this all too well. It's one thing to get a lesion to become inactive. The real test, the true measure of success, is whether you can keep it that way. Can we stop it from flaring up again down the road?
And this table tells that story perfectly. Look at the 5,000 ppm group. It's all about consistency. A huge 64% of lesions went from active to inactive and just stayed there. Solid. Another 30% that were already inactive stayed inactive. Now compare that to the 1450 ppm group. It's just chaotic. Over 60% of those lesions were just bouncing back and forth between active and inactive. There's no stability there at all.
The study actually put a number on that risk of bouncing back and forth, and it's a big one, 3.99 times.
Let's be really clear about what that means. A root lesion managed with standard toothpaste is almost 4 times more likely to reactivate than one managed with the high fluoride stuff. 4 times. That is a clinically huge difference you just can't ignore.
So, okay, the data is powerful, it's compelling, but what do we actually do with this information in the clinic? How do we turn this research into a clear, straightforward strategy? This study basically hands us a simple, evidence-based game plan. First, you identify your at-risk patients. You know who they are, older adults with active root decay or a history of it. Second, and this is the key takeaway, for these patients, you should be thinking of 5,000 ppm fluoride toothpaste as your go-to, your first line of defense, not some last resort. And third, you monitor them, knowing that the evidence points to at least a year of treatment to get that stable, lasting result we're all aiming for. When you put all this evidence together, it really forces you to take a step back and ask a pretty fundamental question about our current protocols for managing this patient population. And listen, don't just take my word for it. I want to leave you with the author's own conclusion from their clinical significance section because they just say it so perfectly. They found that 5,000 ppm fluoride toothpaste consistently inactivates these lesions and, this is the key part, maintains that inactivity, giving us a more stable and effective way to manage these long-term. And so that leaves us with this final question to think about. With such clear evidence for better stability and long-term results, is it time we flip the script? Should high-fluoride toothpaste be the standard of care, the automatic choice for our at-risk older patients? It's definitely some food for thought. Thanks for joining me.